Good morning, everybody. I'm Dr. Anuradha, Assistant Professor of Nephrology, Osmania General Hospital. I thank the organizers for giving me this wonderful opportunity. So, before I start the topic, I would like to know how many of you have seen osmotic demyelination syndrome? Okay. So, my topic is rapid correction of hyponatremia. Should we be worried in 2024? The number of hands raised, I still that I think we should be worried in 2024 still. But the data says otherwise. Let us delve into the details. So, just going briefly about the definition. So, hyponatremia is defined by a decrease of serum sodium below the respective cutoff, serum sodium below 135 millimolar per liter. Definition is supported by the European Clinical Practice Guidelines. Now coming to the classification. So classification, we classify it as moderate, severe and profound. The profound word is from the European guidelines. So moderate 125 to 199 and severe is less than 125. And criteria being serum sodium criteria concentration is taken as the criteria, but the problem is symptoms they never correlate with the degree of hyponatremia. Next, acute versus chronic. Time of development, usually 48 hours cutoff is taken, and time of development we can see that we get referral late, so we really cannot say whether it is acute or chronic. Then symptomatic versus asymptomatic, that is presence of symptoms. Many symptoms especially or aspecific or non-specific. And then hypotonia, isotonic, hypotonic based on serum osmolality. Sometimes ineffective osmols are also measured, so that's the problem with the classification. Then hypovolemic, euvolemic, hypovolemic. Clinical assessment of volume status, we know that it has low sensitivity and specificity. So this problem, how to balance the problems when in acute, that is less than 48 hours, risk of cerebral edema will be more than pontine myelinosis. And in greater than 48 hours, risk of central pontine myelinosis will be greater than cerebral edema. In acute phase, rapid correction can lead to cerebral edema, which is very detrimental. In rapid correction, central pontine myelinosis is more commonly seen if we do it rapidly. But how to strike a balance is a problem, and whether our guidelines, previous guidelines which were established, will it really help? Or is the recent update and recent retrospective cohort studies, are they going to make some turmoil and make some major changes in the coming guidelines? Let us see. So we'll just briefly discuss about the United States guideline and European guidelines regarding the correction. In the acute or symptomatic hyponatremia, it is almost same, except that the volume. In US guidelines, they say that give 3% of NaCl 100 ml over 10 minutes in 3 times as needed. Whereas in severe, they suggest the same, but 150 ml or 20 minutes and repeat as needed. Moderate, it is similar, almost 0.5 to 2 ml in American guidelines. In European guidelines, what they see is give a bolus and just wait and watch, and then again repeat if required. Coming to the chronic hyponatremia and syndrome of inappropriate urea secretion, fluid restriction is the first line in both the guidelines. The use of desmopressin, urea or Vaptins is advised in US guidelines, but not in the Europeans. I don't know, somehow Europeans don't like Vaptins probably. Maybe the reason for it is the TEMPO trial and which has the FDA advisory probably, and then patient related improved outcomes were not taken into consideration. So maybe probably because of that European guidelines did not recommend Vaptin, but they liked urea somehow. But hypovolemic hyponatremia, again isotonic saline, and similarly in European guideline also they use that. And hypovolemic hyponatremia, fluid restriction and Vaptin similarly, but European guidelines still have not recommended, they recommended against Vaptin in hypovolemic hyponatremia. Correction rates, United States guideline, they have restricted themselves to 8, whereas European guidelines had gone up to 10. Now, about the most feared complication, is hyponatremia the only cause of osmotic demyelinating syndrome? Since 1980s, hyponatremia has been seen as one of the common cause of CPM. So one of the most feared complication, that is aftermath of, let us talk little about this osmotic demyelination syndrome. So the aftermath of rapid correction of hyponatremia can be quite unpredictable. One of the dreaded complications is a biphasic illness called osmotic demyelination syndrome. The first phase reflects the gradual neurological illness, and the second phase reflects the osmotic demyelination syndrome, which includes both the central as well as extrapontine myelinosis. So in response to hyponatremia in the acute phase, we all know that the brain makes some adaptations that lower the cerebral volume. So the decrease in the sodium leads to increased intracranial pressure, and which forces the interstitial sodium and water out of brain into CSF, decreasing the, ameliorating the increase in the brain volume. Chronic hyponatremia is associated with osmotically active organic osmolytes from astrocytes, which actually provide protection against the brain cell swelling. Now, organic osmolytes cannot be quickly replaced when brain volume begins to shrink in response to the correction of hyponatremia. So when brain volume falls, it results in demyelination and direct injury to the astrocytes, oligodendrocytes, which are really crucial for remyelination of the demyelination injury and for maintenance of blood-brain barrier. So after rapid correction of hyponatremia, cell water coupled with the movement of sodium and potassium back into the cells, which leads into increase in cell cation concentration that occurs before repletion of organic osmolytes. So these changes in brain result in protein aggregation and DNA fragmentation. So finally this results in ODS, and the clinical features can sometimes be delayed from 2 to 6 days. They are not seen immediately. So after rapid correction, then symptoms like dysarthria, dysphagia, paraparesis, quadriparesis, behavioral disturbances, movement disorder, lethargy, coma, and so on can result. But this will take a delay of 2 to 4 days after your rapid correction. And the typical radiological sign, which as you can see, a piglet sign and the trident sign in the osmotic demyelination syndrome. This is the sign, and most of the time the diagnostic modality would be MRI. But in cases of absence of MRI, even CT can help, but we all know that demyelinating lesion, MRI would be the best. So this is what was feared, and the classification and the guidelines which had advised us to go a little slower in hyponatremia. So going back to the history, what was the basis for these guidelines? So let us go back to history. So the very first report of central pontine myelinosis was first reported in the February 1959 by Adams and Victor. They had identified 4 patients in which again malnutrition and alcoholism was common. Next, in 1967, Mr. Mac Morcom consolidated nearly 69 cases of central pontine myelinolysis, wherein they have noticed serum severe electrolyte abnormalities, which was seen in 33%, and it was associated with malnutrition in 77% of cases and alcohol in 50%. But they have mentioned it as severe electrolyte abnormality, but they did not have any whereabouts about the sodium concentrations. Now came the study by the Bucar study, where they have in the 1997 by Bucar, hyponatremia as a possible risk factor was established by that time. So next, this was backed by animal studies, wherein they studied in dogs and rats. After a correction of greater than 15 milliequivalents in dogs and greater than 16, the rats and dogs had this severe osmotic demyelination syndrome. So now where did we get the concept of giving saline in hyponatremia? So it was way back in 1938, Dr. Helwig treated a woman who looked like almost she was about to die post-hysterectomy 36 hours prior. She was given nearly 8 liters of water by proctolysis, which was the practice date in those times. So Dr. Helwig gave nearly 130 ml of 5% saline, and her symptoms gradually resolved. Since then, the use of saline has been in place. So here and there we had studies saying that there is a literature review by Srijan Tanlkar. Osmotic demyelination syndrome can occur in patients with chronic hyponatremia with a serum sodium of less than 115 milliequivalents despite rates of serum correction of less than 10. So they recommended around 8. Now again, these multiple studies from different hospitals, different have been mentioned. There are 7 hospitals in Jinsar health system where they reported, with the rapid correction, 41% nearly all the patient had incident osmotic dilatation and a documented episode of a rapid correction. Next, landmark studies in severe hyponatremia management. It was first, already I mentioned that Adams was the first person who has established the anatomic description of osmotic demyelination syndrome. Then it is Arif in 1986 who had case series. Then came Mr. Stans, who is an authority in hyponatremia. And then it was desmopressin clamp, which they had advised during 2010, and then 2015 Macmillan study and other study, George study. So let us go into details a bit. So Arif in 1986 study in NEGM highlighted dangers of rapid correction of sodium in hyponatremia. So it was among around 15 females who had this after post-surgery, they had hyponatremia, and they corrected with the, almost 22 milliequivalents in a single day. All had a very bad outcome. Most of them had osmotic demyelination syndrome. And later in 1986 review by Stern, suggested ODS in patients with less than 12 milliequivalents in 24 hours. In 1990, again, CARP case series suggested even slower rate of correction, that is 10 to 12 milliequivalents in 24 hours. So with these data, we formulated the guidelines. So they were only case series, case reports, and review articles are here and there, and based on that, our guidelines were based, both European and Asian, American guidelines. Now, digging into the details, we have multiple retrospective cohort studies throwing a light on the correction. Now this original article, which is quite interesting, they have studied nearly 20,000 patients. This was by Macmillan et al. And don't know the flow diagram. I could not show you. So almost 20,000 patients were enrolled in this, and you can see that among the 20,000 patients, osmotic demyelination syndrome was noted in only 12 patients, and again in that they were not, they did not have rapid correction. So the authors estimated that the frequency of occurrence of ODS was after correction of hyponatremia, and then among 22,000 patients, it was only 12 cases which had ODS, and rapid correction of serum sodium occurred in almost 17% of patients, and less than 1/2 of the ODS cases had this rapid correction. So outcomes, if you can see, so the osmotic demyelination was noted in 12, and the correction, if you can see, rapid correction occurred in almost 17.7% of the cases. So in this large multi-center study of patients with hyponatremia, rapid correction of serum sodium was common, and in order to understand, they concluded that they require further studies. Next, coming to this retrospective study of ICU patients, wherein the ICU patients in 200 hospitals were included, and in this way they showed that rapid correction actually decreased the mortality. So you can see that in-hospital mortality, they have reported that in-hospital mortality, neurological complication, hospital-free days, ICU-free days were much better in rapid correction than in slow correction. Next, coming to this recent study, this is again a retrospective study which included 2 centers in Boston from 1993 to 2018. Nearly 3,000 patients were included, and they divided in 3 groups: less than 6, 6 to 10, and greater than 10 correction rates of sodium, and 6 to 10 was considered as a reference group, and they compared the in-hospital mortality, 30-day mortality, length of the stay, and central pontine myelinosis. In this study, nearly only 7 patients had hyponatremia, and if you can see here clearly in this VA, you can see that patients with normal, normal reference range correction had 4. 4 patients developed ODS, central pontine myelinosis, when compared to patients who had less correction. So it was a retrospective study, and then as I said, So you can see the outcomes here. In-hospital mortality was more in patients who had a slower correction when compared to patients who had a normal correction or rapid correction. And 30-day mortality was also high. Hospital length of stay is also little high in slow correction. So the same thing. So in this study, what they finally concluded is higher rate of sodium correction was associated with lower mortality compared with slower rates. But however, this group had an increased burden of comorbidities such as cirrhosis, heart failure, metastatic cancer, as we all know that they are at high risk of osmotic demyelination syndrome. Now this study does provide the statistical adjustment for comorbidities. They had done multivariate analysis. With observational studies, of course, residual confounding can still occur, and the cause of death was were sodium unrelated in these cases. Slower correction means patient stays longer, and no nephrologist would risk his patient for a dreaded complication such as central pontine myelinosis, even it meant longer stay. So same thing which I have told you, that they have adjusted the mortality and then gave the results. Finally, I would like to conclude that based on the past and now again the recent advances, recent retrospective cohort studies, I can say that central pontine myelinosis predominantly occurs in non-hyponatremic settings. Central pontine myelinosis has many risk factors other than hyponatremia. No matter how hard we try, high-risk patients like malnutrition, alcoholic, schizophrenic, sodium correction at any rate can cause risk. So how much correction is enough and how much is too much? Valid answers to these questions requires population at high risk of complications, both excess and inadequate correction. Now, given the rarity of central pontine myelinosis and outcome, it is difficult to randomize certain patients to different correction rates. So, let us remain open to the high quality observational evidence, and the rarity of occurrence of a feared complication may instead be a supportive of the fact that our guidelines are working in right direction. It means something like on a rainy day, it has stopped raining, but you have put your umbrella down, you have closed your umbrella on, suddenly we don't know when it rains. So we should be wary of, we should still be wary of rapid correction. Thank you.